State University Saunders Center's Echo on Mental Health and Intellectual and Developmental Disabilities, Putting Knowledge into Action series. Let me share my screen with you so we can work through a quick introduction to the project. Like to first address the technical difficulties that we had last week, and due to a new registration process and sending out individualized links to all participants, there was some confusion and challenge. I'm hoping that it was streamlined for this second session. So we want to thank you for your patience and for rejoining us this week. If you're new this week, please feel free to introduce yourself in the chat with your role or title and organization. I'm glad to have everyone here today. Today's agenda will include a quick overview again of the project. We will have a core didactic presentation as well as a case presentation where we will break out into small groups and then come back together for a whole group discussion. Our hub team is listed here. These are members of the hub from the Nighsonger Center: Andrea, myself, Justin, Aaron, and Manisha, as well as Kelly, Lynn, Durga, and Lauren. You'll recognize hub team members with an Echo background or with an asterisk in front of their name. So at any time you have questions or would like to reach out for more information, please contact one of our Nighsonger Center hub team members. Our hub team also includes state and county developmental disability services partners: Chris, Cindy, Kate, Meredith, and Robin. You get to meet them as we go into small breakout groups, or some of you will be with several of our hub team members. We also have health services partners on our hub team: Marianne, Nicole, and Patricia. So again, you'll get to meet them as we go into our breakouts and get to know each other a little bit more as we build this community of practice. An important part about Echo is that it is an interactive community of stakeholders engaged in a common goal. So we really highly encourage you to participate in group discussions, share your ideas and knowledge based upon your own contextual experience and expertise. Case studies really give us a practical lens to focus our knowledge and application, and encourage all of you to consider presenting a case study across our Echo series this fall. Again, the Echo model is an all teach, all learn model. It really encourages interactivity, peer-to-peer learning and mentorship, and collaborative problem solving. So we, again, highly encourage you to engage in our discussions through questions and answers. Feel free to engage in the chat and raise your hand. And especially during the case study, when we're examining recommendations, your expertise and your own contextual settings and background is critical to increasing our understanding of these complex problems and learning and solving these problems together. There will be a session evaluation at the very end. We encourage you to do that 5 to 10 minute evaluation either directly after or soon after the session so that it's fresh in your head. It's mandatory to get continuing education credit, but we highly value your feedback so that we can continue to improve these sessions and series moving throughout the fall and into next year as we engage in new cohort. Without further ado, I would like to move to our didactic presentation. Today's presentation is titled Approach to the Evaluation of Challenging Behavior in Patients with Intellectual and Developmental Disabilities, and it will be delivered by Dr. Kristen Cooper, the Associate Medical Director of the Center for Autism Services and Transition, or CAST, and an assistant professor in the Division of General Internal Medicine here at Ohio State.
Thanks,
Dr. Cooper, the floor is yours. Welcome, and thank you for joining us today.
Thank you all for having me. Bear with me as I share my slides here. How does that look on your end? Can everybody see it?
Yes, that looks good.
Perfect. Okay, thank you all so much for having me here to join you today. My name is Kristen Cooper. A quick little bit about me. I am a primary care physician who's board certified in both internal medicine and pediatrics, meaning that I have the privilege of taking care of patients of all ages. And as Andrew mentioned, I am the Associate Medical Director of the OSU CAST program, which is a program that provides primary care for adults with autism. So my hope today with this talk is to share a little bit about how I, as a doctor, approach concerns related to challenging behaviors in my patients with IDD, and why it's important to consider both medical and environmental factors prior to considering the possibility of underlying mental health diagnoses. So my objectives today, I'd like to start with defining challenging behavior and providing a bit of a framework with which to approach these behaviors. After that, we'll review how I, as a physician, approach these behaviors from a medical standpoint. And finally, we'll end with the discussion of methods by which to help communicate concerns during appointments, including the use of a tool called the Mental Health Passport. My focus today will largely be centered around those patients with limited spoken language, though I hope that the information you'll gather today may be helpful in your care of all patients with IDD. And additionally, as I mentioned, I'm going to focus more so on the medical evaluation of mental health or behavioral concerns, and less so today on the specifics surrounding the diagnosis of specific mental health conditions. So to start, let's define challenging behavior. Challenging behavior is really any pattern of behaviors that is harmful to the patient or to those around them, is destructive, any behavior that contributes to isolation of the individual, and behavior that prevents access to learning and to full participation in the community. So some examples of behaviors that may fall under the challenging behavior umbrella: self-injurious behavior, aggression toward others, tantrums, destruction of property, or even elopement. Estimates vary, but it's been said that at least 50% of individuals with IDD experience some form of challenging behavior. And actually, a meta-analysis conducted by McClintock, Hall, and Oliver in 2003 found that children and adults with autism spectrum disorder were even more likely than other people with IDD to experience self-injury and aggression. As many of us are familiar with, challenging behavior can have many, many negative impacts on our patients, including further stigmatization, rejection by peers, but also even by family members, and staff. Placement in restricted settings, such as specialized education, segregated residential settings, and even in certain cases, institutionalization. Health risks, including injuries, lacerations, and even need for hospitalization, and unfortunately, sometimes death. Impacts on family members with their mental health and well-being as well. And then lastly, the need for psychotropic medications, which in and of themselves have numerous side effects. And actually, there have been interesting studies with some worrisome results that have basically shown that in a survey of patients with IDD, many of them were placed on psychotropic medications for challenging behavior, but in many of those situations, the challenging behaviors were really never fully defined. And even then, local practice guidelines were not followed in terms of appropriate monitoring for these medications and so forth. So I include that on kind of my list of negative impacts. People with intellectual and developmental disabilities, as we know, are really often defined by their behavior. And I think it's important to mention that behavior is an important form of communication and not a symptom of a person's disability. And I think that this is really important to recognize. And also it's crucial to understand that a person might be using behavior in an effort to communicate what their needs are. So really any change in baseline behavior should prompt an evaluation for an underlying source of pain or another contributing medical factor. And I'll highlight this a couple of times, but we as medical professionals really genuinely do rely on information provided by caregivers, as you all typically know patients best. And so please let us know of any new or changing behaviors. So let's get into an example case that will kind of follow throughout my talk today. Trey is an 18-year-old male with a past medical history significant for autism and mild intellectual disability who presents with his mom for evaluation of a 2-month history of poor appetite and behavior concerns. Mom reports that Trey has been with intermittent episodes characterized by yelling, hitting, and biting his hands. She's worried that something is wrong. So when this walks in, sometimes it can be hard to know where to start. But in my practice, I always start, or I try to at least start with the first question being, have these behaviors ever occurred in the past? And if so, was there an identified cause at the time? So often when I ask this question, families will say to me, oh, Dr. Cooper, actually, so-and-so had similar behaviors a few years ago. And actually at that time, we discovered that he had sustained an arm injury after a fall, and we just didn't know. But let's say that for the sake of our example scenario today, Trey's mom tells you that these are completely new behaviors and they've never happened before. So where do we go from there? I'd like to present this HELP framework today as kind of a memory tool or a way to think about how we approach these behaviors at the start. So this memory aid HELP, I adapted from the 2018 Canadian Consensus Guidelines on Primary Care of Adults with IDD. So the H stands for health. So first and foremost, we want to assess for potential physical or health problems. The E represents environmental factors. So we next want to give some consideration to any changes in a patient's environment. The L represents life changes. So we want to screen for any traumatic or distressing life changes or experiences. And then lastly, the P represents psychiatric conditions. So, certainly I do not wish to discount the importance of recognizing underlying psychiatric diagnoses in our patients with IDD. And certainly we know that so many patients with IDD go underdiagnosed or undiagnosed in terms of psychiatric conditions, but especially in those patients who are unable to fully communicate their symptoms or concerns, I think it's very important to consider these other factors before we delve into psychiatric conditions. So we'll start with assessing for possible underlying health problems, some general questions to consider and ones that I will ask. Has the patient had any recent illness? Have there been any recent injuries that, caregivers are aware of? And are there any other new physical symptoms that they haven't already mentioned that could potentially be related? And then from there, I kind of think of myself often as a little bit of a detective. So I will do a general head to toe review of symptoms, meaning I kind of start from the top and talk through various symptoms that a patient may or may not be having and kind of work my way down. And then from there, we'll do a thorough physical exam to assess for any obvious physical findings that could explain what's going on. And I always, should mention that we always want to consider, unfortunately, the possibility of abuse or neglect. So, for instance, I'm always examining for any unexplained injuries or bruises. And then as part of this interview, too, I'm kind of monitoring the caregiver-patient interaction as well. So some examples of medical causes that could explain behavioral changes, and these are common ones that we see all the time: constipation, headache, pain associated with menses, ear infections or wax buildup, UTI, seizures, interestingly, especially so in our patients with autism, dental infections, cavities, GERD or acid reflux, and side effects from medications. So some other examples that I will ask families, when all of this, I'll ask, when all of this started, were there any medication changes that were made at that time, either new medications that were introduced or medications that were stopped, or even dosing changes? Um, I'll ask parents or caregivers, have you tried giving any as needed, like over the counter medicine? So, for example, have you tried giving ibuprofen or Tylenol, and what effect does that have on these behaviors? So, for example, in a patient who perhaps these are related to underlying pain from headaches, families might say, oh, we have tried giving Tylenol and it does seem to help. Or another example for acid reflux, have you tried any over the counter acid reflux medicines and have those made a difference? After we sort of assess for medical causes for behavioral changes, then we want to shift gears a little bit and consider environmental factors. And truthfully, I describe these as being distinct, but often we're doing kind of both of these at the same time. And so some general questions to consider, I ask, have there been any recent changes in the patient's environment? So for example, their living environment, or are there other different new people living in the home? Has their school environment changed, or has anything changed in their kind of school routine? Have there been any recent stressors or traumatic events? So the way that I will frame this for families is to say, take me back to when this behavior first started. Can you share with me a little bit about what was going on during that time? So we'll return to the case now. Mom denies any recent illnesses or known injuries for Trey. And when asked about any other physical symptoms he has had, she does mention that she thinks his stomach's been hurting him because he's been intermittently like pressing on it, she's noticed. And she also says that over the last couple of weeks, Trey has been having liquid stool leakage into his underwear every so often, and that's certainly new for him. So, given the worry about abdominal pain and report of stool accidents, I gather a little bit more info from mom about what exactly she's been noticing. And she says that in addition to the liquid stool leakage, she has found that Trey is intermittently having what she describes as hard, like large stools. And he also seems to be spending like more, like longer periods in the restroom as well. On exam, Trey is relatively well appearing, but his belly does feel a little bit full, though he doesn't seem especially uncomfortable when I examine his abdomen. So, to kind of close out this case, we ultimately come to discover that Trey has had what's called onchoparesis, which is a medical term for liquid stool leakage that can occur when hard, impacted stool collects in the colon. And thereby the colon essentially becomes too full with the firm impacted stool, and so liquid stool sort of leaks around. And so often I will see families who come in and are reporting actually diarrhea because they're seeing the liquid stool leakage, when in actuality constipation is the underlying problem. So for Trey, we start him on a stool softening regimen. And after a few days, mom reports back that his appetite seems to be improving and he seems to be returning to his baseline. So next, I wanted to talk a little bit about some tips for discussion of symptoms and concerns during visits. So I think first and foremost, when you come in to see a provider about new concerns of challenging behavior, I think it's important to list concerns based on priority. So starting with the biggest concern first. When I mentioned I consider myself a little bit of a detective, and with that, I will often kind of really get into the nitty gritty and ask for lots of detail about a specific concern. And I find that when families come in and have numerous concerns and sort of start listing them, it can get a little bit chaotic and hard to sort of stay organized and ask thorough questions through each concern. So I would start with the biggest concern. It may be that different concerns are actually linked and related to one another, but that's sort of in part, for myself as the physician to find out. And then some other helpful information to provide would be the time frame. When did this start? And then frequency. How often are we noticing these behaviors? Are they progressively becoming more frequent over time? Or are they improving over time? Have the caregivers noticed any factors that seem to obviously worsen symptoms or any factors that may improve symptoms? And are there any obvious triggers that we can identify that lead to these symptoms? So for an example, new medications, a change in their living environment, and so forth. And then whenever possible, patients with IDD should be taught to communicate when and if they are in pain. So for example, with pointing gestures to areas that are uncomfortable, answering yes or no when asked if certain areas are uncomfortable or painful. And then again, caregivers should pay special attention to an individual's vocalizations and or behaviors which may be associated with pain. Often, I have family members or caregivers come in and they kind of know what a patient's signs of pain are, and then that prompts them to bring them in to be seen. To finish out my talk today, I wanted to introduce something called the Mental Health Passport. So the one that I'm including here today is one that's been devised through OSU through NYSONGR. There are different examples out there with different other institutions of their own sort of mental health passport tool. But really what this is a tool that can be helpful in identifying a person's history, preferences, need for accommodations, and so forth. But I think it'll just be easier if I kind of walk you through it. So at least in our example today, it includes information. So starting with what the patient prefers to go by, best ways to communicate with a patient, whether that's through talking, writing, text, or a communication device, any accommodations or supports that a patient might need, such as clear or plain language, visual aids, perhaps shorter meeting times or longer meeting times, social stories. For those of you who are unfamiliar with social stories, these are essentially photo-based stories that will walk a patient through any number of things. So for example, within our CAST program, we've made social stories for all of our clinic locations, as we have a few of them now. And so for patients who are unfamiliar with any given clinic site, they can click through a social story, which takes them step by step with photos through every point of, even getting into the parking lot all the way through getting through registration and getting into our building. I've seen similar stories also through like local labs. So walking patients through what a lab draw might look like, for example. Support persons are those who patients feel most comfortable with, that they'd like to be there to help them. A list of their underlying disabilities or conditions. And I'll include kind of here too, I think it's a great idea to make sure that patients keep an updated or an up-to-date list of their current medications with this information as well. The passport tool also includes some information on a patient's background, culture, sort of things that are important to them, likes and dislikes, important things about their past, and then lastly, therapy goals. And I guess I will highlight here a couple of things that I find especially important to include with this information. Any comfort measures or relaxation techniques that work well for the patient. Any warning signs that could indicate discomfort or distress. So for instance, a certain vocalization, perhaps it's hand flapping, perhaps it's foot stomping. Any known triggers for behaviors and therefore things that we should be aware of to avoid. And then lastly, contact information for guardians or family or caregivers. And then the last page here on the mental health passport tool kind of includes a space for reflection on the part of the patient. So for those who are able to complete this sort of reflection in terms of how things are going and what we can change. So in summary, Any concern for new or worsening challenging behaviors should prompt an evaluation for underlying medical or environmental causes. It's really important to consider the possibility of medical or environmental triggers of behavior prior to concluding that behaviors are related to an underlying psychiatric diagnosis. And then lastly, just highlighting again that we medical providers truly rely on information provided by families and caregivers, as you all know individuals best. So we really do trust the history that we gather from you. I'll end with space for any questions.
Yeah, thank you, Dr. Cooper, for that presentation. I, really myself, I really appreciate a mnemonic device to help me remember things, and really like that acronym of HELP to think about, health problems, physical health problems, mental health problems, as well as environmental factors, and then life changes, or different experiences that are new in life before we consider psychiatric conditions. So really nice, and would like to, if you would like to stop your share, we'll bring back our screen with all of our participants and encourage questions from the audience. If there's anything you would like to ask Dr. Cooper, and feel free to add a question in the chat that she could respond to as well. I'll encourage our hub team members to consider any questions or follow-up questions or things that you would like to emphasize that you heard from the presentation today as well. While we're waiting for that quick question, Dr. Whitwer had mentioned some of those additional ideas for the toolkit. I know, one of those was comforting techniques or strategies. Was any other thing missing that you'd like to re-emphasize from that toolkit, Dr. Cooper, that you really think should be added that we can address?
I have to look. Andrea just sent this kind of medically based passport. So I'll have to give this one a little glance over, because that might include some of this as well. But like I said, I think with any patient we see in the office, a list of current medications is important, especially in those patients who may be having fairly frequent medication changes. And then just kind of emphasizing, and I think this really was on the passport, but just sort of emphasizing the importance of like trigger identification, or any behaviors that are like warning behaviors that a person could be uncomfortable or in distress.
We do have a question come through in the chat from Susan, and she's asking, the time frame to get into a provider can be quite a bit in the future. What's a good way to get something addressed more immediately? We all know this issue with the wait list and the time that it takes to get into a provider. Any tips or strategies on that?
That's a great question. And unfortunately, this seems to be a fairly universal struggle for us primary care physicians. But for those patients, so I'm going to speak specifically to patients who are established with a primary care provider, right? I will always encourage all of my patients, but especially so my CAS patients, that if they are looking to be scheduled and kind of running into brick walls and being told that it's a 4 to 5 month wait list, to please ask my team to reach out to me, especially if it's something that they deem as urgent. And then, I can't speak for everybody, but most of us, reading through some of that initial information, we'll do our very best to kind of fit people in wherever we can, especially if it's a more urgent concern. Now, of course, if it's an emergency situation, that's a little bit different, right? And so then, there are times where we have to point people toward services like urgent care or the emergency department. But especially with our patients with IDD, I think the preference would be to have them see a provider who is known to them, who is familiar with their history.
Yeah, thanks again, Dr. Cooper. Really think that that speaks to, a lack of providers as well as something that's problematic and something that we're, really looking to address through sharing this knowledge together. So I'd like to pass it over to Dr. Whitwer, who's going to present our case today. And Dr. Cooper, appreciate you staying online and would like you to really think about any clarifying questions that you might have from your medical expertise or background. And then I'm going to encourage hub members and then all of our members and participants that are joining today, as you listen to the case, think carefully about what clarifying questions you would need answered in order to effectively provide recommendations based on your own expertise and background. And Andrea, before I pass it over to you, I did notice, well, it looks like we had someone on the phone. I'm not seeing them here anymore. So Andrea, to present our case today, the floor is yours.
Great, thank you. All right, I'm going to go ahead. I'm going to attempt to show